Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the Meded 101 Nursing Pharmacology Review course. All right, we've got antibiotics. There's going to be a ton to unpack here, so let's get right into it. All right, first and foremost, I wanted to cover some of the basics in nursing care, some of your likely responsibilities. One of the most important things is to follow that patient clinically, okay? And two of the biggest things that you guys can help out with is clinical response. Is that patient getting better? Is the fever going away? Are the labs improving? Is the infection site improving? Let's say we've got a skin infection. Does that site look like it's getting better? Super, super important, because we, as providers, as pharmacists, as other folks trying to decide what the appropriate medication is, we need to know if that medication is working, and obviously you guys are typically on the front lines in assessing that. Going right along with that, paying attention to new changes, stomach upset, rash, anaphylaxis, those adverse effects, and obviously I'll get into more specifics on each individual agent, but paying attention to new things that are occurring with the patient, that can definitely be indicative of adverse effects. And you guys picking up on that and letting the rest of the healthcare team know what's new can help us definitely pick up on those adverse effects quicker and get them switched over to a different antibiotic if need be. Renal function labs are going to be important. So renal function, hepatic function. This varies based upon the drug we're using, and obviously I'll get to that. Aminoglycosides, vancomycin, very, very important to monitor renal function. They can cause acute renal failure. Hepatic function or liver function. Rifampin is a great example of a medication that can cause liver dysfunction. Okay, so important to pay attention to some of these things and these labs that go with some of these meds. A few other things, superinfection, C. diff associated diarrhea. So as a patient is receiving antibiotics, if you note, 3 days, 5 days, 7 days, 14 days after that antibiotic, patient having diarrhea, worsening diarrhea, bloody diarrhea, worsening symptoms that way, very, very important that we stay on top of that. Giving antibiotics, particularly broad-spectrum antibiotics, can increase the risk of C. diff, another gastrointestinal infection. And then fungal infections can grow as well, oral and vaginal. We kill off normal flora, normal good bacteria in our body, and that can allow other infections to grow as well. Therapeutic drug monitoring, so checking levels, making sure we know when to check those levels, peak, trough, those type of things. Vancomycin and aminoglycosides being the two most common agents there where we may see those drug levels. Drug interactions, QTC prolongation. If you got a patient on warfarin and we're using antibiotics, always ask the question, to the provider who's ever managing that care, do we need to check an INR? A lot of antibiotics interact with warfarin and can cause that INR to go up for sure. Seizure medications, there's antibiotics that interact with seizure meds. So that's another important question. So if you see a patient with seizure history, don't be afraid to ask if there's any interactions or concerns you should be aware of in relation to maybe increasing their risk of seizure while they're on this antibiotic. Definitely a great question to ask. And then binding interactions. Tetracycline antibiotics, quinolone antibiotics, I'll get into those classes coming up here, notorious for binding interactions, and we can essentially render them ineffective if we give them with certain supplements like calcium and iron and things like that. Adherence, that's a no-brainer, making sure we've got the right dose, the right time, and of course, completing that course as directed by the provider. Culture and sensitivity results. This can be super important as far as UTIs, skin infections, and things like that. Getting that timely, making sure the provider's aware of those results so we can, continue on with the appropriate antibiotic we started, or potentially we may need to switch based upon those culture and sensitivity results. All right, let's get into the drugs. So first major class, probably the one you see most commonly used, are penicillin antibiotics. Most common one I see used in practice is amoxicillin. Can be combined with clavulanate as well. Mechanistically, these drugs bind what are called penicillin binding proteins in bacterial cell walls. This basically stops the production of the bacterial cell wall, and if the bacteria can't do that, it can ultimately lead to the bacteria's death, which is what we're going to be trying to do. Beta-lactamase inhibitors, I do want to point them out. They are often used in combination with penicillin antibiotics and potentially cephalosporin antibiotics. And what they do, so a good example here is clavulanate, amoxicillin clavulanate. That's partly in augmentin. What they do is they actually prevent the bacteria from breaking down the antibiotics. So bacteria, some resistant bacteria, have actually developed specific enzymes for certain antibiotics. So it's kind of a wild concept that bacteria have adapted to our antibiotics, but that's in part where bacterial resistance can come from, where you give an antibiotic and it doesn't work for a patient. So these beta-lactamase inhibitors are added to kind of help negate that resistance factor for some bacteria. Side effects: GI, rash, itching, hives. Rarely it can progress to anaphylaxis and throat swelling and things of those natures. Pretty rare that happens, but if you have a patient that's breaking out in significant rash and hives, that's definitely something that should be referred to the attending provider immediately. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology Crossword Puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse. Next class of medication is macrolide antibiotics. A classic example being azithromycin, brand name Zithromax. That's what I see used most in practice if one of these is used. The primary reason being is there are more drug interactions with clarithromycin and erythromycin, so that's definitely a downside to them. Mechanistically, what do these do? How do these kill bacteria? They actually bind to the 23S ribosomal RNA molecule of the 50S subunit, and ultimately this stops the bacteria from producing necessary proteins to grow and thrive and continue to replicate. Okay, so it inhibits bacterial protein synthesis, and it does those through those specific ribosomal RNA molecules. Adverse effect profile: GI upset, probably a little bit more tolerable than penicillin antibiotics, a little less diarrhea typically than penicillins, but still certainly can happen. Unique ones: with this class, QTC prolongation, that can be a risk. So if you got a patient on antiarrhythmics and other medications, a clinician, a provider may ask for extra EKG monitoring in some cases, depending upon the patient and the risk. Rare liver concerns as well have been reported with the macrolides. And then I alluded to the fact already, clarithromycin and erythromycin have significant interactions via CYP3A4. So pay attention to that if you see them prescribed. Quinolone antibiotics. Cipro is probably the most common agent, followed closely by levofloxacin or Levaquin. Mechanistically, these inhibit DNA gyrase and topoisomerase, and this prevents action on the bacterial DNA. So it basically stops it from uncoiling, which the bacteria needs to do in order to replicate that DNA and create more bacteria. So that's how this specific medication class works. Adverse effect profile. Historically, when I first graduated 10, 15 plus years ago now, these medications were used a lot more frequently. Well, we found that there are some risks, significant risks associated with their use. They aren't crazy common, but they can be pretty severe. So there's actually a boxed warning on this class of drugs for tendon rupture, CNS effects like neuropathy and nerve pain, and then QTC prolongation is also a potential concern here. In general, these quinolone antibiotics, they do cover a lot of different bacteria, so they'll often be called a bigger gun or a broader spectrum antibiotic where we cover lots of different bacteria. So that's nice. However, it can kill a lot more of the gut bacteria and good bacteria as well. And so that's something that, we try to reserve these medications if other kind of standard, maybe more targeted medications don't work that well. There are warnings on specific use in less serious infections. So something like sinusitis, a sinus infection, typically isn't life-threatening. So we would generally, want to try to avoid using a, bigger gun like a quinolone antibiotic in that setting. And then, of course, those binding interactions I wanted to mention as well. Iron, calcium, zinc, magnesium. When we give these medications orally and we take them at the same time as, let's say, calcium, what happens is that calcium binds to the drug and it can't be adequately absorbed and utilized by the body. Okay? So we don't get the drug to the site of infection and we potentially risk treatment failure. So pay attention to that. I will say ciprofloxacin, levofloxacin, they come as IV products. We don't have to worry about that binding interaction in the gut. So if we give oral calcium and IV levofloxacin at the same time, okay, that's not as big a deal compared to when you give oral levofloxacin with oral calcium at the same time. So separation is going to be important. I've had situations where I've just stopped the calcium for 7 days, 5 days, however long the antibiotic goes. Otherwise, usually it's 2 hours before or 6 hours after. That's kind of the usual standard separation. If you've got to get tighter windows than that, definitely reach out to the clinician in charge, reach out to a pharmacist saying, hey, when can we give these, that type of thing. That's a good question to lean on those other healthcare professionals for. Cephalosporins, we've got first generation, second generation, third generation, fourth generation, and fifth generation. In general, the higher the generation, kind of the bigger, broader spectrum it is, or it's got a kind of a specific niche for a resistant type of bacteria. So, and I won't get into the weeds too much on that. Just note, pretty much any medication with the abbreviation CEF in it, CEF, is likely going to be a cephalosporin. The first generation, they're generally more focused on what are called gram-positive infections. So you may see them a little bit more used for, like simple skin infections, those type of things. As we get to more like third generation medications, we got a little bit maybe broader coverage, and you may see them used more for pneumonia and things of that nature. But again, tons of different usages between these medications. They actually have the exact same mechanism as the penicillin antibiotics. So what that means is, we have a lot of overlapping coverage there where penicillin antibiotics cover a lot of the same things cephalosporin antibiotics do. But again, it really depends upon that generation and the specifics of each individual agent there. Adverse effect profile going to be very similar to penicillin antibiotics. The biggest differentiating factor is the chemical structure. And so if a patient, this often comes up on drug interaction screen, I think it's a good thing for you to know clinically. Cephalosporins, so let's say you've got an allergy to penicillin and you're putting a patient on a cephalosporin. There is a small risk that there's some cross-reactivity there. So I think that's important to note. Lean on your clinicians, lean on your pharmacists to help you navigate that. I've got a particular family member that, breaks out in a rash from amoxicillin use, but cephalosporins are totally fine. Okay, so definitely depends upon the patient. Again, you'll want to weigh the severity of that reaction. So let's say somebody had a life-threatening reaction from amoxicillin and they've never taken a cephalosporin. Well, that's definitely a risk versus benefit discussion that's going to be had with the clinician, potentially with an infectious disease pharmacist, making sure that we have the safest medication and potentially avoiding that risk of a life-threatening reaction. Maybe there's plenty of other alternatives that aren't in the penicillin or cephalosporin category. So again, if you see that flag come up, definitely don't hesitate to talk with your provider that's prescribing it and make sure they're comfortable with giving it for sure. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse. All right, next medication is nitrofurantoin. Brand name is macrolide. Mechanistically, this drug is actually altered by the bacteria. So bacteria, what are called flavoproteins. And this forms reactive metabolites that actually destroy or disable ribosomal-derived proteins. Okay? So if those proteins, those ribosomal proteins, are inhibited and that function is damaged, obviously that's going to help destroy the bacteria and not allow it to grow and prosper, if you will. Important to look at kidney function with this one. It's recommended to avoid in all patients less than 30 mils per minute. So checking renal function, super, super important, and making sure that kidney function is okay. There is a little bit of controversy about how low we can use that one, but again, that's more of a clinician decision, discretion type of thing. Patients will call you on this one, and they will be stressed because if you don't educate them properly, it can alter the color of the urine. So patients can naturally think their infection's getting worse. Hey, my urine's changing color now. I've got a UTI. which is primarily what this is used for. Now we're prescribing this. Now their urine color's changing, and they're freaking out that they're getting worse, or whatever the case may be. But nitrofurantoin absolutely can change the color of that urine, and it can actually do it to all secretions potentially. There's been reports of that as well. So tears, for example, from your eyes can have an alteration in color and stuff too sometimes. So important to note that. Definitely an important education point. It'll save you a phone call later for sure. There are some rare adverse effects. CNS changes can happen, especially in the elderly, and with poor kidney function. This drug can accumulate in that situation. Nerve pain can happen, and there can be some breathing and respiratory changes. So important to pay attention to that. I will say in the short term, 3, 5, 7 day course, you're probably less likely to see some of those issues. But if you've got somebody taking this for UTI prophylaxis and they're on a chronic basis, you may be more likely to see some of these other rare adverse effects. Tetracyclines, we've got doxycycline, brand name vancomycin. That is by far, I would say, the more commonly used tetracycline derivative. Mechanistically, these inhibit protein synthesis by binding to the 30S ribosomal subunit. So kind of similar to the macrolide antibiotics, where they inhibit that protein synthesis, but maybe a little bit different target there. Depending upon the indication, sometimes used if a patient has a penicillin allergy and a cephalosporin allergy. It's a potential alternative in that situation. Community-acquired pneumonia, that's CAP. It's a good alternative option to maybe some of the penicillin-binding protein-type drugs like your penicillins and your cephalosporins. Photosensitivity. Educate about sunscreen, sunny areas, particularly if it's a time of year where that's an issue, where patients are going outside. They are much more likely to get sunburned, and sunburn bad, if they're out in the sun a lot. So super, super important to tell patients to pay attention to that, stay in the shade, sunscreen, so on and so forth. Binding interactions, similar to those quinolone antibiotics, levaquin and Cipro. If we give oral doxycycline with iron, with calcium, it's going to bind up that drug and prevent absorption. Typically with doxycycline, specifically, it's twice daily dosing. And MRSA is methicillin-resistant Staph aureus. This is a kind of a nasty resistant bacteria. This medication actually does have some activity against that, so it's a potential outpatient oral option if we are trying to treat that nasty resistant bacteria. All right, carbapenems. So these are definitely considered bigger guns, usually reserved for severe resistant infections. These are going to be typically hospital, IV infusion type medications. Occasionally you may see patients go, home with these with the aid of a home health nurse, for example, or an infusion nurse, that type of thing. But, by and large, these are given in an institutionalized setting. Imipenem, cilastatin, brand name Primaxin there, that's a common one. Invans is a common one you see in practice as well. Similar mechanism to penicillin antibiotics. They just have a much better, broader coverage and cover a lot more bacteria, a lot more and different kinds of bacteria. So good coverage against gram-positive infections. So that's like Staphylococcus and Streptococcus type of bacteria, as well as gram-negatives. Gram-negatives often cause urinary tract infections like E. coli and Serratia and things like that. They do not cover that MRSA quite as well, though. So we aren't going to be using these for that specific type of infection. Adverse effect, GI. Occasionally you may see some liver issues there. Thrombocytosis. Imipenem, have seen some issues occasionally with seizures. I didn't put that on the slide. It's not relatively common, but it is something to pay attention to there as well. These generally tend to cover Pseudomonas pretty well. However, ertapenem doesn't cover some specific highly resistant bacteria. So Pseudomonas is a great example of a highly resistant bug that we're always worried about in healthcare settings, along with MRSA, which I listed previously. All right, sulfamethoxazole trimethoprim, brand name is Bactrim. This inhibits bacterial production of dihydrofolic acid by competitive inhibition of para-aminobenzoic acid. So, again, probably the simplest way to put this, it inhibits the production of folic acid that the bacterial cell needs to grow and replicate. All right, sulfa allergy, super common. Pay attention to that. Usually it's a skin type of rash or reaction that patients get with these. So if you see a patient with a sulfa allergy and they're prescribed Bactrim, you better be asking the provider about it, as well as the pharmacy, making sure that it truly is okay to give. Other adverse effects, GI, that sun sensitivity goes with this medication as well. The tetracyclines are notorious for that as well. Warfarin, INRs can go way up. I've seen INRs go above 10. Usual range is 2 to 3. I've seen INRs go up above 10 for sure with this drug interaction. So big one to pay attention to there. Rarely, I will add, I didn't put it on the slide here, but potassium levels can go up. So if you've got a patient on an ACE inhibitor or an ARB or potassium supplement, that might be something to pay attention to there. Potassium levels can go up. There is a risk for crystalluria. So basically stones. These stones can develop, renal stones, and cause issues, obviously, in the bladder and urination. So it's recommended to drink plenty of water with this medication for sure. There are dose adjustments in patients with renal impairment or CKD. In general, good gram-negative coverage, which is why you often see this medication used in urinary tract infections, where gram-negatives are relatively commonly found there. Trimethoprim, more specifically here, I point out that trimethoprim as part of that combination of Bactrim. I alluded to the fact that potassium levels there can be an issue, so pay attention to that. Folic acid absorption, it can increase the risk of deficiency there, along with Bactrim. Phototoxicity, I alluded to that, GI upset, and then rarely you may see some rash, and then potentially increased LFTs or liver function tests. All right, aminoglycosides, these are IV-type medications, gentamicin and tobramycin. They inhibit bacterial protein synthesis by binding to the 30S subunit. Excellent gram-negative coverage, IV only, as I mentioned. Nephrotoxicity, have to monitor renal function. Super, super important. Concentration-dependent activity, so we monitor the actual drug level of, let's say, gentamicin. We monitor that peak level to make sure we're getting enough that we're killing the bacteria and impairing infection and improving that infection. Trough levels are monitored for safety. So the higher those trough levels, the more risk you're putting that patient at for something like nephrotoxicity, okay? The other toxicity that's definitely highly tested is ototoxicity. So ear toxicity, it can cause some hearing problems. And I've listed kind of the target peaks. Just, in usual practice, this can vary a little bit depending upon what we're trying to treat, how aggressive we're getting, and how severe the infection is. All right, now we've got vancomycin, mechanism of action. This inhibits bacterial cell wall synthesis. It's kind of similar to, penicillin antibiotics, cephalosporins, except for it binds a different spot within that bacterial cell wall. So it binds D-alanine groups on peptide chain chains, in that cell wall. The biggest thing, most important thing you're going to see vancomycin likely used for is MRSA, methicillin-resistant Staph aureus. It's a resistant bug. It's problematic in healthcare settings, hospitals, nursing homes, and so on and so forth. Red man syndrome, otherwise sometimes called vancomycin infusion reaction. Red man syndrome sometimes isn't the politically correct way to say it anymore, so they've changed that to vancomycin infusion reaction or infusion syndrome. I've heard used. Typically, it's basically kind of a redness that starts to develop around the site of infusion, typically, and slowing down that infusion rate is the best way to help treat this. Now, obviously, if that keeps getting worse and worse and worse, the rash expands and it's going to all areas of the body and the patient's not doing well, you've got to get the clinician involved if you have any question as to what's going on and that something else is causing the issue there. So paying attention to that, recognizing that, and typically if that syndrome happens, it's likely due to the vancomycin being infused too quickly. Trough concentrations, kidney function, going to be important to monitor that. It can be given orally. However, the oral absorption is terrible. So we don't use this for systemic infections. So a lung infection, a skin infection, we do not use oral vancomycin, okay? Because that drug is not adequately absorbed into systemic circulation. The place where we use it is for a GI infection, and that GI infection is C. diff. That's, if you ever see oral vancomycin, I've never seen it for anything but C. diff. I mean, maybe there's an obscure indication out there somewhere, but 99.9% of the time, if you see oral vancomycin, it's used for C. diff. Okay, so good thing to remember there and put to knowledge. 10 to 20 is the usual target trough level. We may go towards closer to 20 as we're dealing with more serious life-threatening infections that need to be treated ASAP or the patient's going to die. And then if it's not as serious an infection, patient's not that sick, we may get a little less aggressive and have a little bit more time to ramp that up if needed. And obviously, the more aggressive we are, the more likely we're running into some of those toxicities. Less aggressive, we may not run in to as many adverse effects there. Renal function impairment can happen, so that's a big thing with vancomycin as we escalate the dose. All right, linezolid Zyvox, mechanism of action, inhibits bacterial protein synthesis by binding to the 23S subunit. So again, many antibiotics inhibit bacterial protein synthesis. If they're cephalosporins, penicillins, it's the bacterial cell wall. If it's anything else, it's probably a good guess that it's bacterial protein synthesis is what it's inhibiting. Not always true, but a good chunk of the antibiotics do work that way. Unique coverage, MRSA, so that's that methicillin-resistant Staph aureus, and VRE, so that's vancomycin-resistant enterococcus. So this medication kind of has a targeted niche where we use it for specific resistant bacteria. There is a couple of wacky things with this one. So it does have serotonergic and MAOI activity, monoamine oxidase inhibitor type activity. What that means, if you've got a patient that's taken antidepressants and they're going to get prescribed linezolid, that's a nasty drug interaction or can potentially be a nasty drug interaction, okay? So if you know patients, taking antidepressants of some sort, it's always a good idea to mention that to the attending provider who's prescribing that, as well as potentially the pharmacy who is dispensing that as well, making sure we're on the same page and not causing a nasty drug interaction. Oral and IV available. It is somewhat expensive. Other rare things with this medication, myelosuppression, so bone marrow suppression, low white blood cell count, and lactic acidosis. Rifampin, kind of a unique drug. I don't see it used too often, but this actually binds to RNA polymerase and ultimately blocks bacterial RNA production or synthesis. It's recommended to take on an empty stomach. Huge problem for drug interactions. It is an enzyme inducer. It will lower the concentration of many medications, okay? So I'm not going to list them all here, but remember, rifampin is an enzyme inducer and has a bunch of drug interactions. That is very important to remember for sure, okay? All right, seizure meds, warfarin, those I would say are probably the two biggest concerns that I have when I see a prescription for rifampin. Because if those seizure levels, drug levels drop too low, we're potentially going to cause a seizure. If the INRs get too low for too long, we could potentially increase the risk for a clot, stroke, things like that. So a couple of nasty potential consequences if we're not paying attention to that drug interaction risk. Like nitrofurantoin, it can change the color of urine, also potentially tears as well, and other body fluids. So that's definitely a good one to remember because patients will be pretty weirded out by that for sure, and you'll be getting a phone call likely. Good patient education point. Daptomycin, cubicin, this inhibits synthesis of DNA, RNA, and proteins by causing cell depolarization. It's got good gram-positive coverage. It's another alternative, kind of like linezolid for that MRSA. Super important point to remember, do not use in pneumonia. Okay? Daptomycin, if you see it used for pneumonia infection, not a good thing. You definitely need to question that for sure. One unique adverse effect and potential interaction is with statin medications. It can contribute to rhabdomyolysis like statins. So CPK, this is a lab that can be checked, and it's basically indicative of muscle breakdown, muscle damage. And daptomycin, and especially in combination with statins, can increase that risk for sure. Other adverse effects, notable ones, neuropathy has been associated with this medication, or nerve pain, and then eosinophilic pneumonia as well. Tetracycline, kind of reserved a little bit for severe infections. I don't see it too much. I did include it here. It inhibits bacterial protein synthesis by binding to the 30S subunit, ribosomal subunit. The reason you don't see this medication used very often, it does have a boxed warning for increased risk of all-cause mortality. So that boxed warning does exist. Again, generally reserved for when other options are not appropriate. It is a very broad spectrum antibiotic, covers a lot of stuff, but obviously that boxed warning is a huge risk with this medication. Metronidazole or Flagyl, this actually damages bacterial DNA, and by doing that, obviously, you impair how that bacteria functions and can ultimately kill it. Often used for anaerobic coverage, so those are bacteria that don't use oxygen. So generally, it's any type of deep wound or gut infection. Those type of things is where you're probably most likely to see metronidazole used. Avoid alcohol use. This is there's been evidence saying that it's not as bad as we once thought. In general, if patients aren't feeling that well and you're treating an infection, I typically recommend that it's wise that patients just avoid alcohol altogether. But we used to think it was automatically a severe reaction if they had any little sip or anything of alcohol. There's been some studies saying that, okay, maybe it's not as bad as we thought. So in general, when I've educated patients on this medication, I just say, hey, can you avoid alcohol? It's a little controversial. please do your best not to take any alcohol, and I think it would be in your best interest as you're trying to heal from an infection using antibiotic anyway. Like, I think it would probably be best if you avoided alcohol in general anyway. So that's my kind of take on it. And I think it's, probably the best strategy is just to avoid it in general anyway. Big time interaction with warfarin. Gotta check INRs if you see a patient on warfarin taking metronidazole. Super important there. Some GI adverse effects, and then one unique adverse effect is abnormal taste. Some will describe it as a metallic type of taste or texture in their mouth sensation. So be aware of that. Patients can sometimes be weirded out by that a little bit with that medication. Clindamycin, this is another one, inhibits bacterial protein synthesis by binding to the 50S subunit. Similar to metronidazole, it's got good coverage against anaerobes. It does have some coverage against MRSA, which is kind of that sticky bug that's sometimes hard to treat. Orally and IV, it's got what's called a short half-life, so it gets chewed up by the body and eliminated by the body pretty quick. So we've got to dose it pretty frequently. And so that reason, as well as increased risk for C. diff and colitis, so antibiotic-associated diarrhea is really high with this medication. And so, those reasons are why you don't see it used too often there. It can cause some esophageal issues, so a full glass of water, making sure that we fully swallow that medication with some water is super important so it doesn't get stuck and irritate the esophagus there. We do have topical formulation of clindamycin as well for acne. I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. MedEd 101's Nursing Pharmacology Review course is built to make meds finally click. You'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed by pharmacology experts for nurses. Stop memorizing, start understanding pharmacology at meded101.com/nurse.